Okay.
Okay, today I'm Jim Mold, and today I'm speaking with Darren DeWalt, who's a general internist by training. He's a professor and actually chair of the Department of Internal Medicine at the University of North Carolina. And over the past probably 15 years, we've had a number of conversations about goal-oriented care, but none recently. I'm interested to hear, Darren, how you're thinking about this concept lately.
Yeah. Well, Jim, I'm grateful that you reached out because, as you know, I'm really interested in the concept of goal-oriented care and really found your book valuable. Um, and and of course, you and I in past years have tried to collaborate on at least one or two research projects that were trying to get at this in different ways. Um, I I think that what I'd like to describe for you is just kind of how I think about it in my daily practice when I go into clinic, like I was this morning. And um, so one thing that really helps me and that anchors me, I guess, when I think about goal-oriented care are the four categories of goals or four areas that you think are the major life goals that I agree with you of, people having a long life, a good quality of life, a good death, and growth and development. And until you brought it up, I hadn't conceptualized growth and development as one of the goals, but it's once you made that the case and I thought about that with my patients, it's very clearly a goal. But one that a lot of patients don't think about that I will point out for them. Um, and so for me, just kind of reflecting on that framework helps me when I'm approaching a patient and I'm thinking about um, all of the things that we can talk about, all of the actions we could take together, the patient and me, how are they going to affect this patient's goals, particularly, in terms of a long life or what does quality of life mean for them? And I'll give you some examples of that. A good death certainly is something that I like to talk to my patients about. And I'll come to growth and development in a sec. Um, but I'll give you two really tangible examples of how this comes up, like pretty much every week I'm in clinic now. Um, as a primary care doc, bread and butter is blood pressure and hypercholesterolemia. We have really good medicines for both. Treating both can often um, extend a person's life. At least we believe it can. And um, but both can also cause side effects and diminish their quality of life. And now that we're being so aggressive with blood pressure treatment based on the SPRINT trial, I'm finding many, many more patients are having symptoms than I ever had in my career. So I'm all the time as I try to treat to get that blood pressure lower. Many people run into lightheadedness. And so I had this conversation with them about the trade-off. And I'm like, we're doing this because we believe that this could extend your life, but what kind of life is it if you're walking around dizzy? That doesn't make any sense to do that. And I had that conversation with three different patients this morning out of the nine that I saw. Um, and one of them was so focused on his blood pressure and so worried about it that he was toying with just accepting the dizziness because he was so worried about a stroke. And so really just recognizing that this patient's dealing with um, how much will this extend my life? And how much is this interfering with my quality of life? What is it worth to me? And helping him think about those trade-offs. And in that particular case, the patient I'm thinking of, I finally had to say, look, I don't want you walking around dizzy. That's not good. And and I think that the benefit that you're getting from this little extra blood pressure lowering is probably lost if you're dizzy. You're probably not getting benefit from that. And and so um, using that framework that you describe in your book of those four major goals, it helps me to think about that patient. And then with any given patient, I'm interested in the context, how much they're worried about certain things, um, how bothersome is the side effect. Cholesterol, a lot of people worried about muscle aches. And, I always tell them, if you're having muscle aches, you don't have to take it anymore. And but helping them uh, accept that we're balancing quality of life and length of life generally. The growth and development has been really interesting because as a primary care doctor, as you know, we see patients going through really hard things. And many of them are caregivers for other family members, or they've lost a spouse, or they've got something really challenging at work, or they lost their job. And usually in the context of the discussion, they're doing some level of reflection. And often I'm able to point out, one, just how difficult this is and that they're going through something really challenging. But it's almost always the case that I can point out, it's really interesting how you're viewing this. And that suggests to me that you're getting new insight. And by the way, one of our main goals in life is growth and development. And and uh, and it usually makes people feel good to recognize that. And I said, um, learning and growing through life is one of life's pleasures. Sometimes it's a little bit painful when you're going through a hard thing, but it's helped me become, I think, a better listener and able to look for those things that I can point out for patients. So I know a lot about goal-oriented care is often really soliciting the goals of the patients. What I found so far in my ability to implement this is starting with that framework and then recognizing that I can take what I know about a person or what they're saying and help to put it together with one of those goal categories. Um,
Yeah, I actually disagree with you. I don't think eliciting the goals is the major activity. I think that's a mistake that people make. It's an obvious mistake. I understand why people think that, but I think what you're doing is closer to what I had imagined. I mean, I think the goals already exist. You don't have to elicit them. You,
yeah,
you need to clarify them sometimes. Particularly quality of life needs to be clarified uh, quite a bit. I mean, you need to know something about what the person wants to be able to do and needs to be able to do and so forth. And that requires a certain different set of questions. But staying alive, that's a goal. I mean, it only ends when the person says, Uncle, I mean, I've had enough.
yeah.
Um, so you don't have to elicit that goal, just it's an assumption. Uh, the, um, I was wondering as you were talking about the trade-offs, what sort of information or tools you would need in the clinic to be able to have that conversation more accurately? I mean, I know you have some sense about the trade-offs, but what would help you to do that better?
Yeah, that's a great question. And so we have a lot of uncertainty. And some of that's just because I can't keep track of all the evidence. So we do have evidence for a lot of things that isn't put out in a way or isn't accessible to me because my brain isn't big enough to hold it there in one place. So a tool that would be helpful, and I think we may be getting closer to that, is with AI tools, is really understanding, for this patient in front of me, how much benefit are they getting if I get their blood pressure from, if they're hovering at 140 and feeling okay, how much benefit do they get if I get them down to 120? Now, the sprint trial tested that exact thing, but um, you know, there are all kinds of questions like that that come up, especially in the context of other things that are going on in their life. So being able to say, for Jim Mold, my patient, you're not my patient, but an example, um, how much would this really help him?
So there was an
And
article. There was an article published in the New England Journal this past week or so that asked the question in a 75-year-old man who has some hypotension, some postural hypotension, not too bad, but has fallen twice getting out of bed, and he has some aches and pains and so forth, but otherwise is in pretty good shape. His blood pressure is 136 systolic. Should you lower that? What should his blood pressure be? And my reaction to that was, I don't know, because I don't know his entire risk profile. I mean,
Yeah.
he has they said they calculated he had a 20% chance of having a heart attack or a stroke, some kind of cardiovascular event within the next 10 years. Well, what's his life expectancy? It turns out it's about 11 years. So, if there's a 20% chance of having a cardiovascular event before he dies, or maybe as a cause of death, then there's an 80% chance he's going to die of something else. So what other risk factors does he have that we could deal with? And with regard to the blood pressure, they quoted the SPRINT trial and said that he could reduce his risk by 17%. Well, how does that help me? I mean, what was his risk before? Well, I mean, okay, so you can calculate, I guess, if his risk is 20% or something like that, you can reduce it by 17%. But you have to do the calculation, and that's still kind of awkward. What you really want to know is, as you pointed out, are we talking about 2 weeks of additional life, or
Mm.
2 months? That's the information I'd like to have, and we actually did have a tool that would provide that information for an individual considering their entire risk profile. So that's the way I would make this better, is to create a tool that would give you that kind of information that's patient relevant. I mean, I don't,
Yeah.
yeah,
Yeah.
right. But you need but it's not just about blood pressure. So if the goal is to keep people alive, as I said, blood pressure is a strategy, but lowering blood pressure from 136 to 120 may not be the most impactful strategy in this case, or it may be too burdensome, but there are so many other options that you could pick. Well, you could increase his
Yeah.
statin. Who's on a statin? You could increase his statin. You could give him low dose aspirin. You could get him to be more physically active. There are a lot of different things, and you can't do it all.
Right.
So you
Yeah.
need to pick the best strategies.
Yeah. And I think one of the challenges is even though we can do a ton of things in healthcare, and I actually think patients can do a lot of things. Um, so they can change their diet if they want. Now there are pros and cons to that for them, depending on their taste and how they feel. They could move more, although some people run into issues with arthritis or other limitations, although movement helps arthritis. But people, and so those are things that people can do. We've got some medicines. We can treat blood pressure and cholesterol, aspirin for some people, maybe. Um, uh, and there's some cancer screening that, once you get up above 75 or 80, probably has diminishing returns just because cancer screening is really looking out for a long window. So most of that mortality is really not in our control, either with medicines or other preventive strategies, right? The vast majority of it is just going to happen, that we can't change. And so the things that we can change, like blood pressure and cholesterol and physical activity and nutrition, um, if people want to do those things, they can.
I agree, but those things that are most difficult are oftentimes the most effective. So, changing your physical activity level, or
Yeah,
stopping smoking, or stopping drinking, or giving up drugs, or the things that really make a huge difference in terms of life expectancy are the most
yeah,
difficult. But
yeah.
we should be able to give people some idea. If they stop smoking,
That's right.
how many additional months or years of life would you get for that, compared to lowering your blood pressure from 136 to 120? You choose.
Yeah,
One's easy, one's hard, but the payoff is different. but we don't have that.
Yeah.
We don't have that information in front of us. I know we feel like it's out there somewhere, but it would require a fair amount of calculation to actually get to a number that made sense to a patient.
Right. Right. Um, do you think that with the AI tools that are, I mean, it's kind of a blanket statement, but it seems to me that there are more tools that can bring a lot more data points together and try to make sense of them than what we've had in the past.
It would seem like it, but I think that in order to get that information out of an AI program, you have to ask the questions correctly. And that, so I
Hmm.
think if you want the information that we've just talked about, if you want to know how to keep people alive longer, you probably have to, I don't know what you do with the data input, but you have to construct the question in the right way, I think. It's yet to be determined whether it can do that.
Yeah.
I don't know. Because the information that's out there has been derived from disease-oriented randomized trials of very selected people. So I'm not sure the information is actually out there.
You're probably right about that. I do think a lot of the trials did include people with a lot of diseases, but the randomized trials, so they really did focus in on one issue at a time. And I don't know that we really have clear evidence on the various potential interactions that can occur. I mean, it's very interesting that, when you look at older studies, aspirin seemed to have more benefit. Then we developed statins and better blood pressure medicines and a variety of other things. And aspirin nowadays seems to not have the same effect that and so um,
Because
how
we
things
because
are working in our bodies is changing as the technology moves forward, right?
I think it's because of the law of diminishing returns. I mean, a lot of those people are already on statins and their blood pressure is controlled better and they're on better diets and so forth. So, there's less benefit left for the aspirin. You know, I'd like
Yeah,
to talk about this forever with you tonight, and we've always enjoyed these conversations, but we're out of time. I really appreciate it. Maybe we can do it again.
sounds good, Jim. Always a pleasure to talk with you.